We do have a lot of information, so we are going to kind of go through this pretty quickly, but happy Halloween, and I sent a selfie to my kids saying I'm going dressed up as an insurance salesman today. So, yeah, we like to think things big. So we're changing the delivery of healthcare in America. You know, why not? So let's get into it. But first, before we dive into some of the details, benefits are now have to be looked at a little bit more globally with companies out there. And it's about the total compensation. So we're going to suggest just in the first few slides about thinking a little bit differently about your benefits and bringing them into the fold of total compensation. Obviously, salary, fixed salary, bonuses, additional comp is very, very important to your employees. And they're obviously going to be looking at that very tightly. But now with tech companies coming up, jumping up all over the place, equity incentives, you know, phantom stock. If our company goes public, we're going to give you this, we're going to give you that. It's also a very attractive part of employees' compensation. Work-life balances, working at home, staying in different variations that companies can do, how flexible they are is important to employees. Their development, especially the millennials, what can I do that's going to better me in a quicker fashion? And then the benefits piece. People are real smart now with regards to your benefits, and got to keep an eye on your benefits and total compensation and what you're bringing to the table. Healthcare costs are going up. Healthcare trend is at 10.4%, depending on which insurance carrier you talk to. The claim that's $1 today is $1.10 tomorrow. How are you going to manage all those increasing costs with balancing total salary and compensation? So employees are smart. You need to have a more global look, not just at your benefits singularly, but how it brings into your total compensation. So today, we're going to talk about companies with less than 100 employees and over 100 employees. I'm going to focus on over 100 employees. Jeff's going to focus on companies with under 100 employees. But very high level, there is things that you can do. Real quick, by a show of hands, how many people are at a company that has less than 50 employees? Okay. How many people 50 to 100? And how many with companies 100 plus? Okay, good. So that's a good mix of everybody in the room. So companies with less than 100 employees, there are certain things that you can do with regards to your benefit programs. And this is just high-level slides. I'm going to go quickly through them. Benchmarking is very important. What's your company doing, mostly with the local company? So if you're 20, 30 employees, what's the company in Hotbog down the street doing as opposed to the company in California? Salary and health contributions. Somebody who makes $50,000 a year and gets a 3% raise, but then you just increase their contribution for healthcare by $50, just wiped out their raise. So you've got to keep the health contributions and salaries all in balance. Funding options, you have limited funding options when you're less than 100 employees. PEOs could be a consideration. I saw Al from TriNet in here. Private exchanges like Liaison could be an option for companies with less than 100 employees here. How companies work with HRAs and HSAs and could be a benefit to employees. And other perks, you know, if you're less than 100 employees, what other perks can you do to attract and retain employees? And just some fresh fruit Wednesdays, PTO bonus day for your birthday, and dress down Fridays, I think almost everybody does. So again, so that's the less than 100, just high level thinking here for you today. Companies with more than 100 employees, benchmarking is very, very important, but it's more benchmarking to your industry, your financial services industry, the not-for-profit industry. Know what your industry is offering your employees, and that information is there. Again, don't forget salary and versus health contributions. We spend a lot of time on looking at contribution strategies for net cost numbers for the CFO, but what does it mean to the employees and how does that relate to norms of other companies? Definitely need to understand that. When you're more than 100 employees, you do have a lot of options with regards to funding mechanisms, so you need to take, and we're going to talk a little bit more about that today. Wellness programs are very popular for the larger companies now, and how you integrate those. High deductible health plans are usually a foundation for some of the larger companies out there. And other perks out there. My son's girlfriend works for TripAdvisor. They have 3 cafeterias. They feed their employees breakfast, lunch, and dinner. And at 5 o'clock, guess what? The tap turns on. So someone like Barb, Mateo's going to be busy with that. That sounds like a good idea now. We'll see what happens later on. But this is what companies are doing there. Unlimited PTO. Does any company in here have unlimited PTO? Are you scared to death to take any PTO days? It's one of those things that sounds great. My son's first company, and now they don't want to take PTO because nobody wants to take although they have unlimited PTO. But this is what larger companies are doing to attract and retain employees. Work remotely, be more flexible. Those Friday or Monday and Fridays, let the people work from home. Pets to work. Anybody let their pets come into work? There's a couple of there's a couple of companies that do that, and even yoga classes. But those are just some examples. The point here is you're less than 100 employees. There are things to do to recruit and retain your employees. You're more than 100 employees. There are different kinds of things to do to recruit and retain employees, so it's very important. And just real quick, who can help you do this? We think a good consulting firm can help you do this. Very high level on this one. Data analytics plays a big role in controlling your healthcare costs and understanding your own healthcare costs. Setting financial strategies for the CFOs. There's not a CFO. Is there any CFOs in the room? Okay. Highest level of benefits I'm sure you want at the lowest possible cost, right? It's as simple as that. HR wants to recruit and retain, so you have to really have that strategy built with the CFO and the HR people. Have to be on the same page. And usually it should be a multi-year strategy with regards to what you're doing. And making sure all cost levers are reviewed in order to make sure that you have the most efficient programs out there. And then outsourcing inefficiency, HRIS systems. Employees want online access, they want it quick, they want it efficient, they want their information now. HRIS systems are very important in decision-making processes here. And then, so when you're talking about, again, I'm sorry, going real high level because we got a lot to do. When you're talking about financials, getting the best costs, the best plans at the most efficient costs, service and support from your consulting, but compliance. Compliance is the third leg of the stool. It's a very litigious society. Make sure that your compliance is up to date with regards to your benefit programs. And then the final things. If you're more than 100 employees, your fees, your commissions that are paid to your consultant are negotiable. I mean, you can pull those out for majority of our larger clients. And we do a lot in the private equity world. We pay a fee for service. So know that those fees are negotiable and understand what those are within your benefit program. Okay? So that was just a high-level view on just what you can do. But now I'm going to pivot a little bit here into our healthcare delivery system. So roughly, how many people do you think are in America right now, roughly? Number? Anybody?
325 million.
325? Okay, that's a good guess. How many are still uninsured after the ACA?
20 million.
20 million.
50.
50.
80.
What?
80.
80. Well, it was about 49 million before the ACA. And right now, this was in 15, so 325 was probably a really good guess. This had 318 million people. And if you look in here, the uninsured was still almost 29 million people uninsured. So we had about 48 million. So the ACA and all that didn't really take care of the healthcare costs. Didn't take care of the uninsured population. And what's important for my presentation today is private groups, the BUCAs, you know that term, Blues, United, Cigna, Aetna, have about 176 million people are covered there. And Medicare and Medicaid cover about another 105 million people. That's important for our delivery system, what we're talking. Just keep that in the back of your head. Now, another guess. How much does all this cost? Roughly.
Too much.
1 trillion.
1 trillion? Or 2?
What's GDP? It's 20% of GDP.
It's 2017. It's 3.2. When we did this slide in 2015, it was $3.2 trillion. Right? So it's a pretty significant number. So I'm going to kind of go through this slide very quickly. Community rating and under 100 employees. Jeff's going to talk about experience rating, insured, experience rating, self-funded, This is when your claims are going to help dictate your future premiums. And the larger you are, the more your claims are going to play a role. And so understanding your claim data and where your costs are now versus where they're going in the future is where we're going to focus, where I'm going to focus on today. I'm going to focus more on experience rating and self-funding. So maybe some of you have seen this slide. To my right, or to your left, fully insured, non-participating. Anybody have an Oxford Health plan out here? That's a fully insured, non-participating type of plan. You pay your premiums. At the end of the day, you get a rate increase. They don't give you money back. They don't carry money forward. A lot of the plans that are insured are in this bucket. You could be fully insured where you participate in margins and deficits. Minimum premium, now listen real quick on this one. Minimum premium is insurance that looks like self-insurance. Level funding is self-insurance that looks like insurance. Everybody get that? So they are good. There's different products that have different availability for you out there, but as we move down, there's a little bit more flexibility. Self-funded with stop loss, paying your own claims, you hire a third-party administrator, you have protection against large claims, and self-funded with no stop loss are the much, much larger companies, 20, 30, 40,000 employees. Everybody got that? Going to focus on self-funding a little bit here today. Why? Well, you avoid ACA taxes. There's an insurance industry tax of 3.4% that just got put back into insurance plans. You can maximize your cash flow, you have flexible designs, you can avoid state mandates, you got a lot more claim access and data that you had that you didn't have before when you're insured, and you get stop loss protection for the larger claims. But claims can be volatile, so you have to be able to handle claim volatility. You generally have a greater risk of accepting larger claims, or claims over an expected maximum, generally up to 125%. You have to maybe do a little bit more lifting on compliance, and the ACA eliminated lifetime benefits. So you're really unbundling your insurance, where you're paying for fixed costs, administrative fees, stop loss, claims, and reserving for claims that are incurred but unreported. So this is a Cigna trend number right here, and I don't know if you can see this well, but Cigna, this is a 5-year look at Cigna, and bottom line is it's the medical and RX trend that they're showing, and over the years it's anywhere from 6.5 to 9.4%. And then there's a note down here, and I just want to keep this in mind. During that time, Center of Medicare and Medicaid Services that handle Medicare and Medicaid reporting only increased costs for Medicare by 1.4%. In the meantime, Cigna's ramping up there, and I'll tell you why in a minute. So this is a $20,000 claim in 2012, and by 2015, 2016, it's a $30,000 claim, just using the compounding of the claim data. Almost 50% in 5 years. So now, here's a big thing. Remember I said there's 110 million people in Medicare and Medicaid, 176 million people in the private insurance place. We don't pay the same claim dollar for Medicare and Medicaid as we do in the private sector with the BUCAs, the Blues, United, Cigna, and Aetna. And hospitals have an increasingly higher, they bill to their average cost all over the place. New York bills based on their average cost for a procedure, 263%. New Jersey, 583%. This is compared to their average cost for a service. I'll get into that a little bit longer. Connecticut, 280. Pennsylvania, 411. Have you examined a hospital bill lately? One of my partners said, my wife just went in, she got her shoulder scoped, day surgery, bill was $40,000 with United Healthcare. But good news, it was discounted. It was only $12,000. So $12,000 was the bill. Look at this ridiculous break. What was Medicare's reimbursement? $3,500. What was the average cost? About $7,500. Yes?
I have to interrupt.
Sure.
40,000 is, one of those mind-blowing numbers, but 12,000 is not that pretty either for a day procedure.
Yeah, sure,
And,
agreed.
Is anyone looking at the cost to deliver the procedure? To the
Yes, and I'm gonna get into that.
Okay.
That's where I'm trying to get to. And thanks for listening, appreciate it. So, it's the average cost. Think about the average cost. You have knee replacements that are $10,000 for Medicare, $50,000 for the private sector. We're focusing on what's called it's a new concept here, focus on the average cost of a claim. Because the average cost, hospitals have to report the average cost of their charges to Center Medicare and Medicaid services. And that's the average of all their Medicare and Medicaid claims and all their private sector claims. If you pay, so here's an example. We took common procedures, angioplast, bypass, stent, knee replacement. The hospital charge was $445,000. But good news, they got a discount, 50%. This is the hospital charge master, which none of us can see. So those charges for a BUCA was $222,000 for those 4 people. Medicare, and this would have reimbursed $122,000. We're saying the factor average charge was about $146,000. So if you paid on the factor average charge, this company in these 3 instances would have saved $75,000 or 34.2% or 3%. I don't have my glasses on. So
34.1.
thanks, 34.1. It's substantial. If 40% of your healthcare costs are hospital or facility related, what if all of your claims went in through there? What would that do to your calculations? What if you could budget your increase from the CFOs from 0 to 3%? Because this is a huge impact to healthcare trend. Healthcare trend, again, remember I said it was around 10.4%, 10.5%, depending on who you're talking to with the BUCAs. But now, if you took an average cost approach, it's only going to be, it's going to be very low trend numbers. So compounding that is important. Here's another example. This is spinal fusion. And we gave this example is like saying, well, whatever the PPO or the Blues discount 40, 50, 60% on a $55,000 claim, the PPO allowed, whether it's $33,000 or $22,000, the repricer payment, the fact-based payment, is about $11,000. In this particular situation, you're saving anywhere from 49 to 66% on your costs. Still got to try and do the abridged version here today. So how does it work? Everybody you have your network now, right? Your BUCA, your Blues, United, Cigna, Aetna. We're used to just using all the physicians in their network. Is my doctor in my network? Well, this is kind of the retail model. Because why? Because the hospitals are negotiating with the BUCAs, and they get a discount off a charge that you and I are not allowed to see. So if their charge master was $100,000 this year, it could be $110,000 next year, and they get the 50% off a higher number. They get more reimbursement. So what if you just use a PPO network like a PHCS or a MagnaCare, and you use prescription drug product, a PPM, to use, so your employees are used to that. And you use the urgent care centers, all within the PPO network. But facilities say, you go to any facility that you want, okay? Any facility. And what's going to happen is, we're going to pay based on the average cost. We're not going to pay the BUCA cost, we're not going to pay on the Medicare, Medicaid cost, we're going to pay on the average cost that the company publishes, or that the hospital, publishes to Center Care and Medicaid Services. And why? Because that makes the hospital gets a buck. They don't get $10, but they get a buck, and they'll move on. But I know this is pretty high level, pretty quick. But what happens? The employee goes to the hospital, they incur a claim. Third-party administrator gets the claim. There's companies out there that are repricers. They have all the hospitals' reimbursement levels built into their claim system. They reprice the claim, and they send back that $20,000 versus a $50,000 claim. 80 to 90% of these claims are going to be accepted in full because most hospitals will accept around 140 to 150% of Medicare and be good with that. Again, that's 40 to 50% over what Medicare is paying. But, so CFOs get this and like this because they understand the financial model. HR people are scared to death. Definitely, we understand that. The most important thing an employee needs to do is open up their mail and to not ignore their hospital if they get a hospital balance bill. These claims could get appealed. You could get a balance bill, and then you have to send it to the repricer back to the TPA, and they negotiate it, and there may be some areas of issue that maybe they didn't see, and maybe there's a higher reimbursement that goes out. But if they don't, if it still has a problem, or if the hospital's really pushing back, the repricers and TPAs actually have legal representation. Right now, none of you out-of-network claim. How many people here have benefits with out-of-network benefits? Companies like you could go out of network, maybe higher deductibles. You could get balance billed from the hospital, right? But you have no, you may have a broker or consultant who can help you with that, but you have no legal representation to do that. And these plans, they have legal teams, should it go there. And the Fair Credit Reporting Act allows, I guess, within 60 days, as long as the individual gets that information to them, they take the claim and they negotiate the final bid of the claim. Should that go there? And nothing's ever gone to for legal. I'm sorry.
If you're in the middle of mid-year of a Aetna or Blue Cross Blue Shield, right? Can you hire a repricing person to go in and contest the claim?
So the question is, can you hire a repricer if you're under a Blues or Aetna? In the contract, I'm trying to change this, just so you know, and the contract doesn't allow you to do that. So these are some of the things we're trying to amend the stop-loss admin contracts to change that language. Because right now you'll see you can randomly audit 20-year claims at a certain amount. So the question is, right now, an in-network claim, no. We're doing some with out-of-network claims now with some of the companies. Because, why? Because the BUCAs have an agreement with the hospital that says we're going to pay the claim this way. And as long as the claim is 50% of the cost, that's all they have to do. So just for time purposes, I don't know how much, I think I've probably blown through.
Yeah, sorry.
Okay, sorry. This just shows you the compounding effect of the cost. 2 million in claims to 4 million if you just compounded trend. Using fact-based pricing, you reduce it and you move it forward, and you can see it's a huge amount. So I am sorry, I know I could
That's
go
okay.
over, but companies who are interested in this, maybe very, very low, tight margins, new adapters, multi-locations, everybody has to be on board, and it's cost saving to that. So I don't want to go any farther. We'll be here later. We're going to do Q&A, so I'll let